Card Not Silent. This is Rodney G with you. And this is probably the latest edition that I've done. 11:22 p.m. Now we're getting into the thick of things with having to get prepared for the transplant list. Oh yes, the transplant list. Everybody that is looking for a kidney always hear about the transplant list. And it was my turn. It was 2018, and the transplant list had eluded me for years, starting in Tucson. I had lost my weight. As a family, we're stable. We have the cat and dog. That we got the dog back from our friend who's watching the dog. So we are stable and living our lives right now. I was still doing my dialysis, of course, and going to the Vita in San Diego. And at this point, it was starting to get serious with the talk of getting the transplant. I was doing my hemodialysis I was supposed to without any issues. I was taking my medications as I was supposed to. And then I was set up to basically do orientation. You'll do orientation with your hospital that's been selected for you, or you can select it. They'll call you, you go in, do orientation. It's a mass orientation, for at least in my instance. I don't know if everybody has the same experience, but it was a mass orientation. So it was this conference room inside the hospital, and we had the families and the patients there, because they usually, when you're getting the transplant, you have to have somebody with you. They won't allow you to have surgery and then go home and take care of yourself. So you're supposed to really, you have like 24-hour care from a committed family member or friend. And I'll get into those specifics at some point during not this particular podcast, but future podcasts. So you have to be prepared just to know that up front. But in this conversation that we had, it was presented like as a PowerPoint. Also, you would have visits. I believe it was about 2 or 3 hours. It could have been a little more. And we visit with the social worker, the transplant nurse, the coordinators, financial team, and the surgeons. And I believe that's it that I can remember. And each of them had their own PowerPoint presentation. And the social worker basically discussed that when you first start, they would meet with you and do a psychosocial. A psychosocial interview is when they set you down and basically you talk about your family history, including, it could be anywhere from smoking or drug use or any certain diseases that may have happened, like you have a history of heart attacks or heart illnesses, whatever it is. Basically, it's just getting a comprehensive look of really your life and your lifestyle, culture and your beliefs. If you have any religious preferences, what was your family like? Is there any mental health issues within the family? And this also pertains with yourself. So it's very comprehensive. You might even talk about transportation, if it needs to be arranged. So all of those are discussed with the social worker. The other one is the transplant nurse. And the transplant nurse really just kind of tells you what they'll do. You'll see the nurse usually right after surgery. And so the nurse will take you in to your room, and then they get you set up, explain what's going on. You're probably groggy from the medication still. So that's what your transplant nurse will discuss, the type of care that they provide. And they also will provide your medications and kind of explain to you what you're taking. And then probably another one. I don't think I mentioned a case manager, which is a nurse. And the nurse case manager is the one that usually gets all your medications arranged, and they will even help you go through the medication list, and they'll actually show you how to prepare your medications in your pill box. And we was given a pill box with this blue bag, and we kept everything in that blue bag. So all your medications, any documentations that you was given, like the orientation that has your schedules in it, all the doctors, social workers, everybody, the team would all be in that folder as well. So you're supposed to carry that with you basically until you get discharged from the hospital to your other appointments that you'll have to go through. You also, with your nurses, they will talk about your food and what they'll feed you, but you also probably forgot another person. They just pop up as I'm thinking about it. The dietitian. You have to speak to the dietitian. You'll be put on a specialized diet while you're there in the hospital. Although, because now that you have a kidney, things are a little more liberal. So you're able to have a little bit more freedom off a menu. Now, if you've ever been in the hospital when you're doing dialysis, they put you on the renal diet. And the renal diet basically is low sodium. I feel like it's always green beans in there. Green beans is like the dialysis people's like vegetable, I guess. So green beans. And then you can get some, obviously you got to get your protein in. It's kind of bland. They kind of give you like that Mrs. Dash. You get a liberalized diet by the time you get to your transplant, which is a big, awesome relief. And then you have your financial coordinators. And what they'll do is they'll sit down with you, they'll go through your debt, they go through if you have any property, if you have any other assets, if you're getting money from child support, if you have, if you're employed still, what you're making, whose insurance you're on. So that will all be discussed as well. Also, they'll tell you how the process of if you find a donor and how that process works regarding your insurance taking care of the donor surgery. And a lot of times people think if they're a donor, they're going to be stuck with this big bill. I'll say at my time, because I need to catch up on, I feel like it's always changing, but I need to catch up with the latest policies and regulations of today. But at my time, and I still think this is how it is that your insurance will take care of your donor. I know in my case, I believe that's how that happened, how it worked is. So I think the biggest thing with being a donor is making sure that you have time coverage to take off. Because I'm not sure if they take care, I don't know if there's a way that the insurance could take care of like FLMA. I'm not sure if that's possible. But they would discuss that with your financial coordinator. The other ones are the surgeons. The surgeons obviously will talk about the risk. They'll talk about the surgery in general, what happens. They'll talk about the risks. They'll talk about the different type of kidneys that you can acquire. And also the other coordinators in there will also discuss that. And they'll give you the statistical values of success rates, also risk of death on the table as the person that is receiving the transplant. The donor, for most parts, really seem to be low risk, and their healing time is quicker, I believe, than the people needing the transplant. But the risk usually goes to the patient just because we're the ones that's sick. Even with that, the risk is low, but there's always a risk. And I mean, for anybody going under a surgery, I guess there's risk, but they'll give you the statistical values of that. And then a lot of times it depends on the kidney. Some kidneys come with different health risks that may affect you because of your low immunity. But for a healthy person, they don't even know they have this disease, I guess you could call it, can't contract it. And the person don't even know they have it, but because low immune system, that they'll definitely warn you on the different types. And then they'll give you an option if you wanted to take a high-risk kidney. And a high-risk kidney is one that's healthy function wise. It just has maybe, for some, it might have hepatitis. Usually HIV kidneys are usually given to HIV patients. They don't give HIV kidneys to healthy patients that need a transplant. But they'll still go through that anyway, just as to make sure you're fully informed and that you make the best decision for yourself. So that's all discussed. And there's probably so much more that they discuss in the orientation, but that's all mandatory. You have to do the orientation. And then what happens after that is you'll go home, and then you'll get a list of all these treatments that you have to prepare for. So you have to do lab work. You'll have to do I don't even know what they call it. I want to say PEP test, but I think I'm wrong. It's a test that they will, I think they numb the area and then they make a little cut on your arm. They will blot it to see how much blood is on this. It's like a little measuring card. And that tells them how long it takes for you to clot. It's important because if you're not able to clot, you could be at risk of bleeding to death or bleeding heavily. So they get prepared so they know what the average clotting time that you are. So that's one of the processes. And then everything in between is from vision tests. If you have any cavities, you got to make sure your cavities are taken care of. If you have to check your extremities and make sure everything's functioning there, make sure that your lung capacity as well. Make sure, for me, I had to go through this too. I had to go to a infectious disease doctor because when I first moved to Arizona, I got valley fever, which is the mold spores in the dirt. And as the wind picks up, because during monsoon season, the winds just blow through, the most apocalyptic. Sometimes, and as you're new to the system, you breathe in this, and you get these mold spores in there, and it could create issues within your lungs, your respiratory system, and it could be hard to breathe. It's kind of symptoms like the flu, but it's when you go get checked, it'll come up as a valley fever, and you have to take these medications, which I'm gonna go through. So it might be a little longer segment today, and this helps make that valley fever dormant, although it's supposed to still be there. So when I came back from San Diego, they reissued me the medication because I'm back in Arizona, so I wouldn't get valley fever, at least lower the risk of getting valley fever again. And they'll check your feet. They'll just check everything. Like I think I said it before when I was getting tested in Tucson, this really feels like you're like in the NFL combine. And if you don't know what that is, you could Google that and see the NFL combine because they absolutely check everything. Only thing you don't do is run. You don't have to get a 40 time to get a good kidney. That would be something else. You get your kidney off your 40 time in your vertical. Anyway, I told you my brain goes off sometimes. But anyway, that's pretty much the quick, like the snippet of your transplant orientation and setting up your labs and all the medical. Hopefully you don't get sick in between, right? Sick enough to get you off the list, we'll say. But if you just get like a normal cold or something, like I think I end up having, once again, I'm going back to my butt. I'm tired of talking about my butt. Like a rectal abscess again, I think. Or I had some bleeding and I had to lay on the table with my wife in the room and this old doctor. Richard Pryor tells a joke about Johnny Bench, and he said his wife was in the room and she was about to give birth, and he got his wife's legs up in the air and the doctor squatting down like Johnny Bench. And Johnny Bench was a baseball player from back in the day, and he was a catcher. So obviously catchers have to squat and look. And so that's why I felt like that doctor was squatting and looking. And then he gives me the old finger prod with my wife there, and she gladly wanted to watch it. And then start cracking up at the end of it. I should have her tell the story because she thought it was a hilarious thing that I had to be bent over this table. I said, yeah. I said, really funny, really funny. And now I think about it, it's funny, but it wasn't fun having a finger up your butt at the time. So let's go to the medications. And so my whole purpose of that was just to say that didn't take me off the list. And I don't think I even had to go to the hospital at that time for that. Now, this is not the medications that I had taken while I was on dialysis. So this is the medications that I take now, which a lot of them are different, and they'll change your medications by the day. So you may have a medication that you'll take. We want you to go pick this up. And then by the time you go in and do your lab work, your doctor may get the lab results and call you back in that second day and go, this is elevated, so we're going to put you on this medication. And then you go get that medication, like in another 2 days, you go get your labs checked again. And the doctor will go, well, this one went down, so we're going to lower this one, but we need to add you another medication because that takes care of this. And then eventually they may, in 3 days, say, okay, don't take that medication no more. So I had thousands and thousands of, luckily I have insurance, I did, thousands and thousands and thousands of dollars of pills that I never used. Some of them were brand new pills. Maybe I used one pill and you can't do nothing with them. You can't donate them to another country. Like I couldn't take them across Mexico and give them to people who need the medication or give them to somebody else so they wouldn't have to pay the money in the United States. So eventually I kept those medications until I knew that it wasn't going to take them no more and dumped them at the CVS. They have a container that you could dump your old medications in. So I took all those medications, thousands of dollars. I mean, some medications you'll get for a 30-day supply and they're, that's like $10,000. And I'm not even exaggerating. I found that out because some coverage issues happens and they're like, oh, you owe $10,000. I said, well, that's not going to happen. I'm going to die before that happens. So then we get it adjusted. So right now, then in case you're wondering, like I know it's like 22 minutes already. So let me go through the medications I'm currently taking just so you understand like the depth of it. Because a lot of people might think, oh, maybe you take 1 or 2 medications and that's, no. I take prednisone. Prednisone is a steroid. And that steroid is actually helps with, so I don't get a rejection of my kidney. Now at Scripps, they're actually a no steroid hospital, meaning that prednisone or steroids. Some hospitals that you go to automatically give you the steroid. Now, because my kidney reacted differently and they decided to try the prednisone out and it ended up working, I take a low dose of prednisone just to help make sure I don't have any rejection, because I had several rejection issues at the time. And I don't want to go too in depth because I'll probably talk about it again. And then I'm not going to be able to pronounce all the names. Fromoside, F-U-R-O-S-E-M like a Mike, I-D-E. I take that one. And that one is basically a water pill, LASIK. It's probably a good time to explain. I'm not a doctor. I'm a patient that has all these medications. I'm reading them off. So I'm not a doctor or medical professional. I'm just reading off to you what I take. If you need anything or you have questions about your medications to see maybe you need something adjusted, contact your medical professional or your medical team. Vitamin D. I take vitamin D. And that has really nothing to do with the dialysis or the transplant itself, I should say, but from another surgery that happened, which I'll explain to you. So they gave me the vitamin D. I guess it all intertwines. Nephrogen. And this is I believe that is one of my high blood pressure pills, because I still have high blood pressure even though I'm on the I got the kidney, and I think that's common as well. I think sometimes you just have these issues. Mycophenolate, that is one of my anti-rejection medications. Carvedilol is another high blood pressure medication. Then I take what is the common name, Pepsid. And I take the Pepsid. Now, I didn't take Pepsid for a long time. And then probably I would say like about 6 months, I've started having acid reflux where I literally wake up choking on acid reflux. Like I'll wake up, cough. And one day I had it coming out my nose, out my mouth, and I was gasping for air. And I got up and basically did a neti pot and just cleared out my nostrils, and I had water coming out of my eyes because it was just one of the most horrible things. So now I'm on the Pepsi, and that doesn't, I won't say that. I don't think I take it as recommended. So then sometimes it works, sometimes it don't. So I take a couple of teaspoons of apple cider vinegar with water, and that seems to help with the acid reflux, like when I'm ready to go to bed. Tacrolimus is another anti-rejection medication, which I take a lot of anti-rejection medications because apparently being African American, my body is a little more resistant. I get that Zulu warrior spirit in me. So that Mandingo warrior is fighting off this European medications. So they just kept up and up, up and up and up and up and up and up my medications. Go, we never seen somebody take this much medications for anti-rejection. And I said, that's because I got the African spirit warrior coming out of me fighting it. So for fluconazole is the medication I take for the mold spores for that valley fever. I take a baby aspirin. That's because I had a heart valve replacement. That was probably as a result from either the dialysis or they didn't find it when I was a baby, but it got worse as I was on dialysis, my heart valve, apparently. I didn't know I had a heart valve issue, but so that's why I take that. And that's also why I think they gave me the vitamin D back again. And then the final pill that I have here is warfarin. And warfarin is also because the heart valve replacement, it was calcified. And a lot of times when you are on dialysis, and if you don't take your binders correctly, and the binders are the ones where if you are eating a lot of like potatoes or protein, you will get those, you got to take those binders and the protein, and I don't know, like the chemistry of it. But those things that create the phosphorus basically binds to the elements within that binder. That's what helps with that itching. You may feel that itching. That's what helps with that itching is those binders. But if you don't take those binders like you're supposed to, or you don't listen to your dietitian and you continue eating large amounts of potatoes and meat, well, that just ends up calcifying your different parts of your body, like your heart valve. And I think it's your veins or something, but don't quote me on that. Calcifies, maybe it's your arteries. I don't know, ask your doctor. But this one calcified my heart valve a bit. So when I had that done, they put me on warfarin because I have a mechanical valve. If you do you might hear me zipping up my mail. I have a little bag a lunchbox that I carry my medications of it in. It's a little monkey kid's lunchbox. But as I lost my train of thought. But as you get those medications, also those change as well. They pretty much stay the same, but if you have some complications, they'll change. And sometimes you may have white blood cells may go really low. Mine did anyway. And then you might have to take a shot to get those red blood cells back up or white blood cells back up. So I had that done too. So it's always continuing. It's always evolving. And even I think this is kind of like life until there's no more life, is your health continues to be monitored and adjusted. But that's better than the alternative, right? Better being dead. So like I said, this was a really long one. So it's going to be fun going through this one. So you may not get it until tomorrow because it's already 11:53. At least I wanted to get it done, and then I'll have it done sometimes in the morning tomorrow, and then you can listen to it. Stick with it. I know it's a long one, but this is probably one of the episodes that has the most information that I provided to you so far, especially with that medication. And remember, if you're feeling off or something feels weird, contact your physician. contact your medical team if you have a primary or if you have your transplant team still. Make sure to always remain in contact with them. I don't have the medical knowledge. I just know some stuff, and I didn't give it to you in any eloquent manner. I just is giving it to you as I have it, as I always like to leave off. Thank you for being here, and if you wake up, you have a purpose.